Okay, so welcome everybody to this ABW seminar. It's really a pleasure for me to introduce the speaker of today, and that is Jeremie Gallien. He's professor in management science and operations at the London Business School. He's written many papers on supply chain management and global health delivery. And what I also appreciate in his work is that he really combines more theoretical and also applied research. And I think that's a very nice combination. And this talk is more on applied research. And I think the topic is really very, very inspiring. So, Jeremie, the floor is yours.
Thank you.
Sorry, Jeremie, before I give you the floor, if you are willing to, okay with, let's say, also opening the camera so that we can see the faces, that is fantastic. But if you're not willing to do that, it's also okay, of course. And also, if there are questions in between, that is possible. You can just use your microphone or raise your hand. So also, in fact, questions in between are welcome. The floor is yours, Jeremie.
All right, thank you very much for this kind introduction. And so this talk is going to be about a project that was started a couple of years ago. All my co-authors on this project are listed here on this slide. Hopefully everybody is able to see. I'd say the main academic co-authors includes George Chen, who's here with us today. So hi, George. And our jointly advised PhD student, Yuhang Du, who is a PhD student at the London Business School. We also have been working on this with contextual experts, including Jody Laurie, who's a professor at the nursing school of the University of Michigan, two colleagues from the University of Liberia and the Ministry of Health of Liberia. And then finally, there's a software development team that is led by Dimitris Panayotou, who's a former master's student of mine at the London Business School. So before I continue further, I should mention I have Dick kindly asked me if I wanted questions and so on. And so if you have a question or want to make a comment about any of the idea or slides, or please, as we go along, please don't hesitate to raise your hand. And then I know that Dick will be monitoring this and interrupted me, and then we can maybe interact live, which probably would be more fun and pleasant for everybody than if I'll have a Q&A session at the end. All right, so I'll motivate this work. Motivation, of course, is maternal health, perinatal mortality affecting mothers and infants. And one statistic that I find very striking is that as of just a couple of years ago, so it hasn't changed very much, there were 2 women who died every minute on average through the year from pregnancy and childbirth complication. And about 90% of these births were preventable and occurred in rural area of low-income countries.
Correct. Yeah.
The key question was, why do all of these pregnant, delivering women die in low-income country? And there's some statistics that show the very strong relationship there is between maternal mortality, which shows on the vertical scale of this graph. It's basically counted as number of deaths per 100,000 births. And then on the horizontal axis, you see the proportion of birth without what's called a skilled birth attendant, nurse, midwife, doctor, and that's on the horizontal axis. So what do we see from this graph? Basically, the key aspect is that there's this really strong correlation between the number of births without a skilled birth attendant and the maternal mortality. And what we also see is that the low-income country, both have the highest maternal mortality and the lowest proportion of assisted birth, and that's actually motivated the one of the oops, trying to go back to be able to move between slides. Okay, it seems to be back. Probably had a slide delay there. Right. So this has motivated maternal mortality, one of the key sustainable development goal within the health area that was agreed in 2015, goal 3.1. And then because of the extensive research that sort of links maternal mortality with the presence of a skilled birth attendant, the main operational target indicator that was associated with this goal was the proportion of birth attended by skilled health personnel. So why is it that in low-income, resource-constrained environment, many women do not have a skilled person to assist them during birth? That's of course the very low density of health resources and in the remoteness of women. So what this work that we've done focuses on one intervention, all right, that's generating quite a bit of momentum, excitement, as an intervention to increase the coverage of skilled birth attendant, the presence of birth assistant. And that's essentially to put a residential facility near a health clinic, which is equipped with obstetric, basic or comprehensive obstetric services, so that women who are pregnant and live in very isolated location can move there for some time before their expected due date, so that when their labor starts, they're not going to be, quote, really far away from any obstetric services that can, a skilled birth attendant that can help them, but rather because these maternity waiting rooms have been built really near, essentially have access to a skilled birth attendant who sort of resides in the premises and or work just a few meters, 100 meters away from the residential facility. There's fairly extensive observational studies literature that documents the positive impact of these waiting homes in terms of maternal and infant death and stillbirth. But there's a number of challenges that are also they've also been observed. Okay, there's a number of countries that have hundreds of maternity waiting homes. Liberia is one of them. Zambia is also cited. Latin America also, Ecuador, Peru, Cuba, all these are countries that have a fairly extensive maternity home network. Ethiopia, Tanzania, I believe as well. And there's a number of challenges associated with their operation, their upkeep, their perception by local community, their support, logistic things having to do with continuing sort of proper nutrition and providing food supplies to the women who stay there, and so on. But there's one that we've really focused on that's been documented is the limitation of the accommodation capacity that they have. So in other words, there's been a number of reports of the problems that arise in the fairly frequent situations where the waiting home are saturated and overcrowded, documentation of unsafe, or uncomfortable, poor hygienic conditions. The pictures that I'm showing on these slides are basically some pictures from the nicest waiting home that George and I have visited in Liberia. But we've also visited waiting home that where you see this mattress on the floor here, and so women sleeping on the floor, sort of not very clean sanitary condition. I mean, I'd never want to send my daughter or partner to give birth in some of the places that we're visiting. And so there's this limitation of the capacity. So basically the key research question that we've set out to answer and trying to develop interventions in the field to address is the question of how to make the best use of limited accommodation capacity in the catchment area of a waiting home. That is, how do you maximize the benefits to the population in that catchment area of that limited accommodation capacity available? And so specifically, what we've looked at is, in terms of how to use this capacity, is which woman should be assigned to stay in a waiting home. Obviously, all the women who sort of live a few minutes away from a health clinic would not benefit, so it wouldn't make sense this, but exactly which one beyond the immediate vicinity of clinics does it make sense to assign to a waiting home? And if applicable, when should they be sent to a waiting home in relation to their expected due date? So in other words, the recommendation that we're looking at is one that's made before the birth, at some point during the antenatal consultation, when the only information that's available in terms of when the delivery will take place is the expected due date. There's some uncertainty around this. I'll go into this in a minute. And the question is, at that particular point, what is the time in advance of the expected due date that one should recommend a particular pregnant woman to go to an MGH, if at all? So that's the first core research question we're taking on. The second one is how important. So the second one, this one, is to do with capacity planning, network management. We're going to talk very much about this. We're only starting to sort of look at the academic modeling questions of this. But the third question I will tell you about, and is a very important one, which is how impactful are these potentially better capacity utilization guidelines? How important are they to public health in those regions with limited waiting home capacity? So how much of a potential impact could this work make at all? So I've just stated research question. Now would actually probably be a good time before I dive into the model and so on and our approach to make sure no one has any questions or comments before I go further.
Any questions for Jeremie?
Speak now or remain silent forever. No, but I'm just stopping now because I'm just defining the problem, and I'm going to sort of switch to how we go about addressing it shortly.
Can I ask one short question?
Oh, yes.
Are there women that kind of resist going to these facilities, or do they feel that they're too far away from home or from their known surroundings? How do you deal with that if that's ever the case?
Yeah. So the adherence to these guidelines that we're developing, and I would say the personal experience and comfort of women affecting their decision to go, to stay, and how long to stay, are really critical things that I'm not going to sort of present a lot of research about today. But they're really critical. I mean, in those observational studies about waiting home that I mentioned, you've got a lot of mention of women who don't want to leave their home because they have all sorts of house chores, care responsibilities, employment. They might want to work and help generate income in their household until the very last minute. And so you've got this very clear tension, sometimes that are being reported, between the sort of the environment, house environment, in which women sort of feel maybe some pressures, internal, external, to stay, even if it's very remote, very isolated from places where they could help during their delivery, and then of course the benefit of getting skilled birth assistance. But that's definitely a very, very strong feature. We have sort of in country of Liberia that has sort of invested a lot of resources in advocating and advertising the importance, and has made 100% skilled birth attendant deliveries their national policy. Sort of these issues are more accepted, and it seems to be easier for women and accepted to spend some time in waiting homes, okay, before. But I think that's a very high generalization. That's not very deep and just based on my experience. So hopefully that
Thank you.
sheds some light on this issue. The individual level women decisions affecting their ability to go to waiting home is a very important and complicated topic. Okay, so if there's no further question at this point, but again, sort of feel free to jump in, okay, and interrupt me at any point. I'm going to sort of share so first of all, the high-level background on the timeline of labor, which I will need in order to present our work, and then tell you a bit about sort of the academic work and the modeling that we've done around this problem. Basically, I guess most of many of the women in the audience might know, but in my experience, many of the men don't. So this background might be useful. There's variability in the duration of human gestation. So basically, women see the onset of their labor to happen at very different time. But the good news is that there's very good documentation, quantitative documentation of the distribution of when labor onset happened at the population level, okay, statistically. But there is a lot of variability here. For those of you who want to sort of try to follow the math aspect, I'm going to refer to that historical statistical distribution of the time to the actual onset of labor as with a letter D, as in delivery, and the probability distribution cumulative is going to be denoted by F. So when labor onset happens, the first stage so labor has three key stages: the sort of early labor, then the childbirth itself, then the placenta delivery. And for this work, what turns out is going to be really important is the early labor phase. Okay, and clinicians basically divide this early labor phase into two stages. One is called the latent phase. That's the one that starts immediately with the onset of labor and the first contraction. And the second one is the active labor. That's characterized by much more intense, for many women, very painful contraction and cervix dilation that's more pronounced, which is the active labor. And the first phase is, I'm going to latent phase, as it's called. I'm going to refer to it with an L, and the distribution that likewise can be found in the clinical literature, I'm going to refer to it as G. All right, so the cumulative probability distribution of the latent phase duration of labor. So that's my background on the labor process, and now I'm going to start talking about the model that we've developed in order to help make these decisions and help optimize our capacity of waiting home is used.
May I ask a question, Jeremy?
Please.
So those distributions, are they universal, or may they differ maybe per country or?
Yeah. So I have they differ by a number of factors. I have come across a study that compares the latent phase duration and duration statistical distributions of women in some country in Africa with the studies that have been done on the largest sample, which turns out to come from Sweden, and that sort of didn't really find very strong differences based on the country alone. But there's very important differences that have to do, in particular, when you look at latent phase as well as the actual labor onset, having to do with how many children a particular woman has delivered before. And so that's the concept of parity. And so on the whole, for example, labor tends to be much faster, sort of the latent phase, for so-called multiparous women than for who've had sort of birthing experience in the past relative to nulliparous women who have not, for whom it's their first delivery. Okay, and that's one of the critical factors. There may be other factors driving sort of systematic drivers of variation across this different distribution, but that's the one that really seems to be critical.
Thanks.
So the geographic setup, sort of scope that we're looking at, is essentially a catchment area. And within this catchment area, sort of considering all of the locations and a number of facilities. And what we're defining here is taux R, so the time to reach the nearest health facility, the nearest skilled birth assistant for a woman living in that location, which is highlighted. And the first key idea that essentially we had that helped us sort of develop a data-driven approach to this waiting home management decision was basically realizing that without any waiting home, just facilities that you always need to travel to from the point where labor starts, we've defined this concept of the birth before arrival. Okay, and that's the concept is that you will not make it to that nearest skilled birth attendant, to that nearest health facility before the active phase of your labor starts. And the reason we're defining this concept is that the active phase of labor in sort of many reports of sort of woman experiences through birth, there seems to be sort of a lot of consensus that it's either unsafe or very painful or impossible to continue traveling for a lot of women when it starts. Okay, when what's called the active phase of labor starts. I should emphasize the human experience of labor is very, very different. Okay, and there are a lot of exceptions to this, but because of this documentation of the sort of the really much increased challenges and sort of also sometimes clinical importance of having an assistant when active labor starts, it seemed reasonable to us as a construct to basically use the extent to which a skilled birth attendant is present to help a woman when the active phase of labor starts as a key metric, okay, for this work. And so we're considering this care axis metric of the birth before arrival, and we're specifically measure it with the available data by saying the probability that you have a birth before arrival, either you arrive to an SBA or the SBA arrives to you, is going to be the probability calculated through the clinically documented latent phase duration. So it's basically the probability that your latent phase is going to be shorter, that the time that is afforded to you to reach help is going to be shorter. You're going to have less time than the time it requires for you to access help. And so that's our main metric that we're going to use here. It's it's got this simple, very simple form that can actually be estimated from clinical data. Okay, and some estimate of where a woman lives, how long it takes her to go to a clinic. All right, I should make sure no one has a question at this point. So I'm going to add on to this shortly. Okay, so what happens when there is a waiting home? So the scope that we're considering is a region with one single waiting home, potentially multiple health facilities that will not have accommodation capacity, but there's accommodation capacity in one waiting home, and that's the catchment area that we're looking at. And we're now going to explore and ask ourselves, what should be good referral policies? That is, how much time, so this capital T, which is a function of where a woman lives, how long it takes her to get to her nearest health facility. So that's the kind of capacity assignment policy we want to determine. That's going to be your decision variable, if you wish. We're basically saying a waiting home is a place that a woman goes in advance, tries to go hopefully in advance of the onset of her labor in order to protect herself from the situation where the labor will start from a very remote location. So provided you have a plan to go to a waiting room at that particular sort of recommended move date, capital T, what is the remaining way in which you could still face a birth before arrival, sort of an unassisted birth? That would be if you're sort of potentially more unlucky in a way, and one, have your labor onset that starts before the time when you've been recommended to move to the waiting home, okay, which can happen because of this variability of when labor onset happens. And then conditional on this happening, that is your labor onset happens earlier than your recommended move date, conditional on that, you try to go to a health facility, so the labor onset finds you in your home, and then you try to go to a facility, but you still don't make it in time. That is, your latent phase of labor is shorter than the time it takes you to go there. All right, and so we're basically here in this model assuming that these two sources of uncertainty, that is the uncertainty around the onset of labor and the uncertainty around the latent phase, are independent. Actually have not found clinical studies indicating, that it's the case or that it's not the case. So for the time being, it's just an assumption we're making. We could revisit this if we find clinical data or develop it and so on. But for the time being, we're assuming this because that's the simplest thing to work with conceptually. And so what it means is that given a policy to move at a particular date, capital T, in relation to the expected due date, the probability then of birth before arrival for a woman will be the product of these two probabilities, the first one being labor starts before the planned move to the MWH, and multiplied by the probability that the time to travel to the nearest health clinic is longer than the afforded latent phase of labor. All right, and so that's I'm going to tell you about optimization and so on, but I think this might be the single most impactful idea, because it sort of results in this very simple model that has these very important consequences and so on that I'm going to elaborate on. So I'm going to stay a little bit of time discussing the potential implications and impact potential of this particular model and ways in which we've tried to facilitate using that simple probability model in the field. But again, I want to make sure that everybody's following at this point, and there's no question on the input, data, output, what we're trying to do. Okay, sounds good. So you can view this as an objective, all right? We want to maximize, sort of minimize probability of birth before arrival over some population. And as such, sometimes just developing ways to sort of quantify and show the results can be useful. So as I mentioned in my response to you, Dick, it turns out the latent phase of labor is different for nulliparas and multiparas. These are, two tables for each one of these two cases, showing the type of output that you get with this model. And what's really useful is that you're getting, I understand it sort of originally, I've not come across quantitative models that help in sort of deciding when to go to waiting home ever, anywhere so far. What you find is that you can use this model from the previous slide to compute the probability of having a unassisted birth, okay, which are the numbers that are being shown here, based on different scenarios. The first one in the first column of these two tables is, if you're not going to stay at all in an MWH, if you just plan to move on your expected due date, okay, well, you have roughly 50% of your birth, basically starting before. And then you see how for women living at different distances to the nearest health facility, which is what's being shown in each row here on the vertical side, you can use this model to evaluate the benefits in terms of reduction of the probability of birth before arrival to move earlier and earlier to the maternity waiting room in relation to the expected due date. And sort of the tables, these tables that we sort of shared and discussed with practitioners, I mean, were, got feedback as to whether, this would likely be useful. It'd be useful to sort of try to implement and deploy that type of very simple probabilistic-based assessment of the risk of unassisted birth at the time of the antenatal consultation, which is when women are being advised, and that's a natural opportunity for women to sort of discuss with care providers their antenatal consultation and how they should make birth plan arrangements. And so we've basically developed a device, a cardboard device that is inspired after the pregnant wheels that are used in obstetrics to implement the prediction of the expected due date based on the last menstrual period. So they're making these wheels based on when the last menstrual period was, and then you get a prediction of when the expected due date is. So this kind of device format is well known and used and widespread. The only thing is we've developed one that implements the model for predicting the risk of an assisted birth as a function of the parity. Okay, so I'm only showing one side of this device, but there's two sizes, with one for nulliparous woman. And then I have a little animation. So basically you line the estimated travel time on the outer circle, which basically corresponds to the time for a woman to access a skilled birth attendant. And by sort of positioning this arrow to the appropriate travel time that's required, the little opening in the middle disc that turns around basically gives the same output that I was showing you in the table, which is, in this particular example in which the little video shot froze, you're looking at a woman who takes about 4 hours to go to the nearest clinic, which is very, very common in rural areas. And then if that woman basically does not, she's had pregnancy before, so she's got less time to make it. And so if she doesn't use a waiting home, her chances of an assisted birth, her chance of assisted birth in this case is only 50%, so about half. Okay, so it's basically flipping a coin here. But you can see that on the sort of the part that, so you have to rotate the head a little bit. I apologize for this, but you can see that as you move to the waiting home earlier and earlier, that probability of assisted birth common, and that's a kind of device that one could conceive being used to implement a threshold for the minimum probability of assisted birth that you would want to base recommendation on, for example, if you want to be systematic. And it turns out that's a device that would be key to implement an optimal policy that I'll tell you about after I start telling you about optimization model and so on. So there's a full paper that describes this particular device and this particular birth before arrival probability model that for which the reference is shown over here. All right. Should I continue on at this point, or are there questions or comments?
Yeah, maybe I have a question. So can you say something, some more about who is using this device?
Yeah, so I'm sort of going to show the instructions that were so basically two key stakeholders here: the care provider, who would be the main person using the device, and the patient. And we're basically currently organizing, setting up a sort of a deployment test, as it were, to get feedback and refine things and understand related research opportunities. But for that purpose, we've developed instructions for the primary user, which is a care provider, typically a nurse, who runs the antenatal consultation at the time when the expected due date is calculated. You have sort of physiological measurement, sort of checking on the clinical aspects as well. And then the idea is to sort of have a patient information sheet on which the output of that risk assessment and the recommendation of what to do will sort of be written on paper and handed to the patient. So that's for the access risk. I'm going to tell you about optimization. Dick told me we're an OR crowd, an OR myself, so obviously that's the first, and how you use the maximum capacity in the best way. But I should say, in the spirit of, being humble and I think realistic on the impact on practice, the part that I'm about to tell you now is really what, if we ever publish this, paper, which is about to finish, is going to get it published in a good academic journal. I don't know whether this part about optimization will have the greatest impact as opposed to, this disk that I was showing you before. Okay, so, and that was a little bit of a humble reckoning for me when I wanted to be honest about what's the relationship between different kind of work we can do and we like to do, and what has the largest impact in the field, and at this point I have some uncertainty, but I'm sort of asking myself question. In future we'll hopefully tell, because we want to try to roll out different implementation devices, both for the device and the implementation and the sort of the optimization, but I'll tell you more about this shortly. So now we're explicitly capturing the capacity constraint, the number of beds, and so what it means is that this recommendation guideline policies that we're looking at is subject to a capacity constraint. And I'm sort of, for the sake of time, not parse out all of this expression, but it's basically on the left-hand side, the expected number of beds that would be used when you implement a particular assignment policies. And so intuitively what's going on is that if you assign a woman or recommend her to come earlier relative to expected due date, she will consume more accommodation capacity, okay, in expectation. And so what this inequality here reflects, that sort of feasibility condition, that in expectation you don't want to have a recommendation policy that results in an excessive number of bed being occupied or sort of women coming here to stay relative to the physical number of bed and sort of room space that's available. And so what it means is that we can basically now consider an optimization problem where here the objective is what's called utilitarian. So we're trying to minimize the total expected number of births before arrival in the entire catchment area, subject to the capacity constraint, by trying to solve for the recommendation policy. Right, that's what this is. And it turns out in a global health setting where people worry a lot about equity and access to health and so on, what I think is the sort of more aligned formulation with respect to these objectives is the egalitarian version of it, where you're basically trying to develop the assignment policy that's going to minimize the worst case probability of birth before arrival that's experienced by any woman in the catchment area. Okay, and that's essentially what this math here says. And what's really nice about this, which was also a bit of a surprise given it's kind of a calculus of variations problem, is that and sort of Yang, of course, worked a lot, and that's going to be a big part of our dissertation. This model is entirely tractable. So we can prove the uniqueness and existence of a closed form optimal policy for the egalitarian utilitarian problem. I'm just going to show here quickly the egalitarian, which basically shows that you're not recommending sort of, there's a time threshold, travel time threshold, sort of every woman living closer to the nearest health facility than that threshold should not go to the waiting home, but beyond that threshold for how far you're living, then you start progressively recommending earlier and earlier move date, and you do so that above the threshold, the probability of birth before arrival is the same. And essentially, because it's an egalitarian formulation, you're arranging this policy so that all of the resources, no resource is basically used to decrease the probability of unassisted birth for any woman in a situation such that there's another woman out there with a worse, higher probability of unassisted birth, right? And that's essentially what these graphs are saying. I'm going to skip really quickly because I want to tell you a bit more about impact and evaluation and all this, but we can compare the utilitarian policy, which effectively does not use as much resources to the women who live very far away. So you can see that their probability of birth before arrival tend to be a bit higher, and also more actively recommends that some women living closer than in the egalitarian policy should go to the waiting home. So because it's focused on the expected total number of birth before arrival, as opposed to the worst case, the policy will sort of dedicate more resource to those women living a bit closer to the facility than the egalitarian policy does. All right, so you can see they're potentially fairly complex to implement because you've got a continuous change of the recommended date. So there's this idea of the zone policies that we've actually heard back as part of field visits in rural Liberia, which consist of saying, hey, we're going to have a zone within a radius of travel distance where we're not going to recommend any move to a waiting home. And then beyond this, we're going to have maybe 2 or maybe 3 zones whereby the recommendation is going to be the same for every woman inside that do not, sort of progressively concentrate do not, as it were. Because of course that's sort of simpler to compute, and you can, and there's things I'm not going to talk about, but that you have sort of discretized approximate integer programs that you can use to compute the optimal 2-zone and 3-zone policies. So just an example on one particular county in Liberia, this is a map of the probability of BBA without any waiting home capacity. So you see the worst case is going to be 72% of birth before arrival, and then over the entire catchment area, on average, you'd expect about 17 births before arrival per year in that particular region. And I'm showing now not the probability of birth before arrival, but the time of suggested move to the waiting home by the optimal egalitarian policy, if you assume 8 beds are available. And so you see there is sort of around all of the facility where you can get help. This red zone means they're not recommended to go to the waiting home. And the egalitarian policy basically progressively increases, recommends earlier and earlier moving day, where the sort of the maximum is going to be for those women in the sort of southwest corner, the most isolated remote. And the 2 key metrics here is that you sort of reduce the maximum probability of BBA from 70% for those women to 0.6%, with just 17 beds in that area. And the expected number of BBAs in the whole region is, goes down to 2 from 17 birth before arrival per year. And then you see, for illustration, what a 3-zone egalitarian policy looks like in the exact same situation. And so it doesn't do quite as well numerically as the optimal egalitarian, but it's got only 3 recommendations. Don't go, I think, go 1 week before, go 2 weeks before, sort of similar recommendations, which are represented by the orange and the green areas respectively. I mean, in this case, it probably would be more impactful to talk about green, being the safe zone around the facility than do orange and red, like the traffic lights. But anyway, green is the ones that should go the earliest. And the sort of the performance, increases a bit from 2 to 3 births before arrival per year. But you can see it performs pretty well. So that's just an example. But what we've done is sort of, there's a couple of things we've done to have more realistic assessment of the impact here. The first one is to capture systematic differences across women. So this was a single class model that I described to you, where the only thing differentiating women is where they live. But not explicitly from a policy optimization standpoint, recognizing the fact that there are systematic differences based on parity. And so you see this distribution of latent phase and sort of cervix dilation history based on parity. You have sort of a systematic differences in the uncertainty around labor onset And that's driven by parity, but that also is driven by the prediction methods. And so for some women who don't remember the last menstrual period, this LMP method cannot be used, and you're basically using a much coarser, less precise method based on physiological measurement, external, to sort of predict expected due date. Then sort of the middle method is last menstrual period, and then the sort of the gold standard method in high-income area is the ultrasound. And there is variability in the probability distribution around the predicted due date of when it's going to happen. So that and that's a standard sort of predictable systematic driver of differences across women. And then another one that we sort of realized by, through field visit is that there's very different proportion of access to motorized vehicle in different locations. And that's just a little sample of the data set that we collected in this whole county I'm going to tell you about. And that makes a huge difference, of course, because it's sort of, for a woman living, everything else being equal, living in the exact same location, it means the ones with access to motorized vehicle will face considerably lower risk, potentially, of unassisted birth. All right. So, and that's, again, you can determine this up front, and that predicts, drives differences there. So, so we've expanded the numerical theoretical results, the model, to what we've called a multi-class of women, and that's indexed by K, and that's basically a class here would be an example of a class, one corresponding to one value of this class index would be a woman without access to motorized transportation who is multiparous, that has, a child before, who's had maybe their expected due date determined by a very inaccurate method, physiological measurement. She didn't remember last menstrual date. There's almost no ultrasound, okay, that there is, so, and so this is the concept of class that we're looking at. And these classes basically drive different latent phase distribution, and they also drive different labor onset distribution. So it makes sense to separate those things as we're looking at the overall objective, and separate potentially policies that would explicitly take into account these differences between classes of women at the time when you're making a recommendation. Okay, that makes sense. So it turns out both the utilitarian, egalitarian version of the multi-class problem also have optimal, unique, closed form solution. And these types of policies with additional restrictions can also be implemented through discretized MIP approximations. And what I'm going to show you now is maybe in the last sort of few minutes, some numerical results that we've developed in order to realize an evaluation of the potential impact of developing this type of policy relative to the status quo in one particular fairly large representative region of Liberia, which was recommended by our Ministry of Health collaborators to pick as Bong County. And so you see on the map where it's located. It's a little bit north of the capital, Monrovia. George and I have sort of extensively traveled there as part of our trip. And that's basically, you're talking about a small sort of a region that has 500,000 people, about 14,000 births, and 160 maternal deaths per year, and also has 45 health clinics, so basic emergency obstetric services available in 45 different locations, and 22 maternity waiting home, totaling 171 beds. Okay, so the key data that we've collected to perform this impact evaluation include the spatial birth rate. In World Pup, you can get expected number of births for every square kilometer in sub-Saharan Africa, and so we've used that. It's an estimate, of course. Travel time and distances from OpenStreetMap. The ministry told us the exact location, the number of beds, and so on in that county. We painstakingly collected data and organized the data collection effort with the regional health county team to get estimates of the proportion of women having access to motorized transportation, okay, everywhere in that county. And we've also gotten from the clinical literature sort of labor onset and latent phase duration distribution. So I'm going to show you the results. These are results averaged out over this entire region, okay, about 500,000 people. There's a lot of numbers here, and I apologize. I should mention the paper is hopefully will be public soon. It will have all of this impact evaluation. But you basically see the benchmark, which is highlighted in red on top, which is that in that entire region, if you didn't have any maternity waiting home capacity, we would predict an expected number of births before arrival of 543 per year. And the worst off women would face individually sort of the most remote corner of that isolated place in that county, a probability of unassisted birth as high as 72%. Okay, and so these are the key statistics here. And then we've tested optimal policy. Here I should mention, all of these are policies assuming complete differentiation and complete knowledge of where a woman lives, but also if she has access to a motorized vehicle or not, and also what a parity is. And I'm saying this because later on I'm going to show you results, what happens when, if we, for example, did not have all of this information, either for information reasons or because it'd be too complicated to implement. And what you can see is that for most of these policies, we're sort of reducing with 171 maternity waiting home beds. The high level is we're reducing the number of unassisted birth by roughly 400 per year, which is not negligible at all, and is on the same order as the number of reported maternal death. Okay, so you see this metric does not seem completely out of disconnected from public health, sort of established public health measures. And then the other bits that you could observe here is that there's actually not much benefit, almost no benefit of the utilitarian relative to the egalitarian. So in this particular case, there's no benefit in terms of total number of BBAs of doing the utilitarian as opposed to the egalitarian. So the egalitarian for both theoretical but also practical reasons seems to be really adapted. And of course, as you increase the number of zones in the policies you're considering, you're getting better and better result. But the 3 zones seems to have a really good sort of hit. Beyond that, basically 4 and 5 zones, you're not really hitting much more increasing impact. So I'll mention here then the work we've done to understand the impact of information. And so what these results here emphasize is that what really matters in terms of reduction of unassisted birth is to know whether a woman has access to a motorized vehicle or not. But it doesn't really matter quite as much to take into account a parity, develop different policies for multiparous, nulliparous women, and so on. Okay, and so that's what these results are saying. You're obtaining almost all of the benefits of the optimal policies of the 3-zone policy when you know the vehicle access, motorized vehicle access, and not the other element of classes. And so I'll sort of skip on this, and not knowing this conversely cost 100 of unassisted birth per year. Okay, if you don't take that into account. So this is an optimistic scenario whereby you're allowing out of catchment stays. So you remember there's about 22 waiting homes, 45 health facilities. The current policy is to only use the waiting home for the catchment areas of the health facility that they are built next to. So in other words, the capacity is not pooled across health facility catchment area, okay, as our model basically suggests. In practice, they're not pooling. And so these are the results that you obtain when you allow this, what we call out of catchment, the MWH stay, which means you pool that capacity. And in order to evaluate the potential impact relative to the current status, the impact of the current capacity that's used and the way it's used, what they're doing is to not allow out-of-catchment stay, in which case the sort of evaluation is that basically the worst cases, of course, come from women in catchment areas without an NWH, and the worst unassisted birth probability is 72%. But you basically, for roughly all of the scenarios, even with sort of good policies that seem to be aligned with what they're using, more or less these 3-zone policies, taking into account the home location. So the red one is pretty much the legacy policy, and the green one would be a possible recommendation. You basically could double the benefits of the existing capacity in terms of waiting home beds, not by changing the number of beds and changing capacity, but by changing the way it's used, by doing 2 things. 1, by pooling that capacity across different facility, and 2, by using an optimal 3-zone policy that takes into account the knowledge, differentiates between women who have access to motorized vehicles, and the ones who don't.
Jeremy, I'm looking at the time.
Yeah.
Yeah.
Yeah. So I think I've made
Okay.
my main points. There's another intervention, open web-based mapping tool that allows people to play with these kind of maps and develops this kind of knowledge at the geographic level that our development team has been working very hard to build, and that we're hoping to deploy. But I'm going to conclude now. So I guess my takeaways, in this particular case, I learned that it was useful to sort of spend a lot of time before you jump into a project and have sort of the academic pressure to publish, get in the way of really understanding the problem and waiting that you have gotten that knowledge to formulate and commit to a particular sort of model formulation and so on. I learned through this project that it's very useful and sometimes humbling to ask, okay, will what I'm doing really help in practice? And maybe develop some humility and lucidity around this. It is useful, as maybe the DISC example, to think of what's the path to first impact, what's the path to a little bit like the Scrum methodology for software development. I sort of believe in this when it comes to interacting with practitioners and realizing practical impact, sort of reduce the time until you get feedback from the field about something you're trying to make them do differently, essentially. And then the thing that was absolutely key was for me to leverage our network so that we could work and collaborate with people who really knew about maternal health and maternity waiting home in resource-constrained environment. And I will stop here.
Thank you very much, Jeremy, for this very interesting talk. Really very inspiring. So let's continue with questions, but I can imagine there are already people leaving because of the time. So please leave if it is time for you. But if you have questions, then please stay. And yeah, we give you the floor for questions. Are there any questions? So I see that Lorraine, you have questions, so you can just use your microphone.
Yeah, thank you for sharing your work. It's very interesting. Sorry, I apologize. I'm a first-year bachelor student, so I hope you'll forgive me if my question seems a bit naive. So if I understood it correctly, the DISC may not be that exciting, but it has the potential for a significant impact. But I imagine that developing and promoting such a tool must come with a lot of challenges, especially in making it user-friendly and getting people to adopt it. So my first question is, could you share any best practice or interesting experience about how you navigated those challenges and ensure that your work was not only effective, but also embraced by the community. And my second question is, what do you think was the biggest challenge in this project, and how did you address that?
Okay, thank you for great questions. I think I should be pretty humble in terms of giving advice and best practices here relative because of the stage that we're at. I think it's very important to when you're sort of trying to have an impact in a cultural, professional, health environment where you don't live every day, to sort of iterate, okay, and sort of work in an iterative mode where you're sort of really getting feedback, modifying things along the way. I'm not able to share a lot of knowledge on this particular implementation because we're just at the early stage of getting feedback and finding out what nurses and midwives in the field are thinking about this. This is just ongoing, so I can't do this, but I can tell you in other projects, every single time I sort of flipped the switch on having an intervention that was changing the practice of what people were doing, I've always learned 10 times more than what I was expecting relative to the drawing board stage about what's happening, how the field works, what's important, what's not important. There's always sort of, and I think along my career, I've sort of develop some humility as to how much you can predict what's going to happen in reality when you're in the drawing board, even though we like to pretend ourselves as modelers who can conceptualize reality, of course. I think and I'd say in terms of best practice for doing this, I mean, the host of this talk is one of the very, very few people who who've won several Edelman competition prizes. And so he knows a lot about this, but I'd say that this particular competition of applied OR work offers a really good library of successful projects and best practices for having an impact in the field with analytics and OR work. And so, it's all published in the Informs Journal of Applied Analytics. There's sort of presentation about, given by the finalists of these prizes, and it all constitutes very, very good material to sort of learn about what works when you're trying to have an impact on practice, I think.
Thank you very much. Are there any other questions? If not, then I have a question. So could this analysis also be used, for example, in calculating, for example, the capacities of the houses and maybe even also the locations of the houses?
That's right. So basically, this this tool that we're developing at the moment is basically a let me see if I can share this. Is basically a tool to help. Oh no, wrong. Okay, wrong one. To help the ministry and sort of more generally any central health administration make network planning decisions. So decide. I'm just going to share this really briefly. So that's the latest version of this web-based open tool, and you can basically sort of play with the number of patient beds that you're assuming for different facilities. Consider differences, rerun scenario of how these beds are best used, and then in terms of sort of look at the results. So first of all, disseminate potential assignment policies through sort of HTML file that you send to the different country team, but also look at sort of the impact of making changes in capacity located in different places on the expected total annual number of BBAs and sort of the health impact on one side. So what we haven't done yet is develop optimization model for network capacity planning, which may or may not, be as effective as actually giving a tool that allows practitioners the ability to make sort of different, consider different scenarios. That may not be as effective because in practice, this is the kind of things where it would be hard in a network facility location types of model to capture all of the things about funding restrictions, ease of implementation, strategic direction, projects being built in terms of care access and so on. So that there may be room for academic contribution there, but we haven't decided to go full side on the academic component, but the sort of the scenario analysis component of network planning, that this is what essentially I'm showing you here.
I see. Yeah. Very interesting. Are there any questions? If not, then thank you very much, Jeremie, for the very interesting and inspiring talk.